Support for To The Point comes from Bausch & Lomb.
Beautiful and healthy looking eyes? It shouldn't be a compromise. Lumify Eye Illuminations, developed by the experts at Bausch & Lomb exclusively for the sensitive eye area. To cleanse, nourish, and brighten. Lumify Eye Illuminations, only in the eye care aisle.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hi, Jessilin. How's it going?
Hello, Jackie. Things are good. And hello to all of our listeners. We've got another exciting episode. We have somebody here that is going to throw down some dry eye wisdom. I'm super excited.
Okay, so we love having colleagues that we admire on the podcast. We love having friends on the podcast. And isn't it great when one person is both of those things? We are so happy to have Jake Lang on our podcast today. And I'm going to tell you a little bit about Jake. One, Jake does everything. He's the anterior segment chair for the Academy. He's the Intrepid Eye Society vice president. He's a diplomat of the American Board of Optometry. He's the medical director of the dry eye services at the Associated Eye Care. And he's the co-director for the Associated Eye Care the optometric residency program. He does everything. I'm going to tell you a personal story about Jake. Wait, I have a great story about Jake. So I don't think I've ever told this story, but Jake and I became friends like many years ago, it feels like now. And I don't even know how we met exactly. I feel like it was online. But anyway, we became friends, and I was telling Jake how I was very early into like my lecturing journey. And by very early, I mean, I think I maybe lectured one time or something. Like I had never really lectured before. And I was kind of thinking I might want to get into it, but the idea of it was like so terrifying for me to like lecture, like, oh, I don't know. So I say this to Jake, and then Jake forwards me this email from the Academy. That's their like call for lectures. Okay. And he's like, hey, Garlic, we should do this. We should do a lecture at Academy. And I was like, oh my God. Like I was, intentionally vague about answering that. Like, oh yeah, maybe, like I was like, I don't know. So I was like so nervous. Like Academy's not like easing into lecturing. Like that's very intense. And I was like so nervous about that. And so I was kind of hoping he would just like, we weren't that close of friends. I was kind of hoping he would just like forget and like feel like I was lukewarm on it and just kind of drop it. So I respond like kind of like, oh yeah, I don't know, wishy-washy, maybe. Literally the next email I get is Jake being like, hey, I submitted an outline and your name's on it. So we're going to lecture. I've submitted this lecture to Academy. And I was like, what? I wasn't even serious. I don't know that I want to do this. I was like so nervous about it. But this is a good point that sometimes you just need friends to like push you into doing things that seem really scary, because it does make you a better lecturer. And so my advice to anybody who's around Jake Lang is if you want to lecture, don't tell him that, because he's going to create an outline and he's going to put your name on it and you're going to be lecturing who knows where. Welcome, Jake Lang. Welcome.
Thank you, Jackie. Thank you, Jessilin. Yeah, I'm getting better and better at voluntelling people things. Like it's definitely one of the leadership qualities I've acquired over the years. And I actually remember that story because I remember being like, you were like, what? You submitted it? And I was like, oh, I'm sure it won't get accepted. It won't get accepted.
And it did.
And of course it was. Yep, it was.
Accepted. And I was like, oh my God, I'm so sweaty thinking about it. Like, oh my God.
Anyway, clearly Jake has an eye for talent. When you were telling the story where you met online, I thought this could go in a very different direction. But it's good to know. No, Jake is awesome, and he's so encouraging, right? He brings everybody to the table to a very teamwork approach, which is just very, very rare, right, for optometry. So it's awesome.
But that's not why he's really here. He does actually know a lot about dry eye. Like he does actually have some knowledge, just besides signing people up for things.
My favorite thing to talk about with Jake is innovations because I feel like he's one of the people that's always in the know. He knows what's coming down the pipeline and he has such a scientific brain so he can get to the nitty-gritty details of like, the pathophys of what we need to know, but he has a real talent for being able to explain and educate in a way that like makes sense, right? And feels very like conversational and real world. So I feel like so excited to be able to like tap his brain a little bit about some maybe dry eye innovations that are in the works. So we're gonna like just pick your brain and you just throw down that knowledge and tell us what we need to know. Innovation's always exciting. We've got some really cool things that are coming out. But before we can really embrace those, we got to know like the backstory, right? Like kind of the science behind it so we can help best fit for our patients. So there's this interesting drug in the pipeline that involves a RASP inhibitor. What is a RASP inhibitor? What is RASP? What do we need to know?
Yeah. First off, like, thank you. Huge compliment for me to like be able to get the word out about things and be smart enough to interpret some of this, research and innovation that's going on. And I think that what we're all going to see in this next generation of innovation in ocular surface disease is completely new things. And so I want everyone to understand like this stuff, especially the stuff we're talking about tonight, like this is completely new. This is not cyclosporin, right? This is something that we as a profession are going to really need to dive into. We're really going to need to take some time and understand this better because we're moving on. We're moving forward. This is going to be the next generation of um, medications and therapeutics. We're done being broad. We're going to get really focused into the nitty gritty. And we've seen this like in other sections of medicine, right? Like rheumatology, just think of all the different biologics they have now. And I think eye care is the next one to take this on, where we're going to be doing more things, more specific things, and delivering better care to our patients because of that. But the science is here. We just got to embrace it and find the right things that'll work for our patients. So that being said, RASP are radical aldehyde species. So RAS are these radical aldehydes that are created at the instance of oxidative stress. So when something stresses your ocular surface, like one of the very first things that are created are these radical aldehydes. They're really like fast acting molecules that are going to react with the tissues even before you say ouch, right? This is upstream of ouch. So these are things that are happening at a cellular level, affecting tissues right when the oxidative stress happens. And so there's a molecule coming that's a radical aldehyde species inhibitor. And so this is going to kind of like remove a lot of those very, very, very initial, very, very, very upstream initiators of inflammation. So even before cytokines are released, right? This is pre-cytokine inflammation. We're going to modulate, not really inhibit, but modulate these radical aldehyde species. So we're going to turn down the volume. We're going to turn it down, chill everything out. I know you want to die, little epithelial cell. I know you've been stressed out and you just want to die, but maybe we'll keep you alive for a little while. So that's where we're going with radical aldehyde species, these RASP inhibitors. This reproxalab is the molecule. And again, it's a lab, right? So we're talking about MABs and labs and all these things that we're seeing in other areas of medicine.
On that, so if we think about like that inflammatory pathway, right? Like I'm thinking of other things, we've got steroids right on there. Even thinking about a lot of the immunomodulators inhibiting T cells. So this is more upstream. So can you kind of give us an overview of like from A to Z, kind of where that in that pathway that falls?
Yeah. So this is at like A or B.
Yeah,
This is
yeah.
that how far upstream it is. So if we think of like T cells, they have to be like signaled, right? Like something's wrong here, something's broken, come over here and help fix it and tell more about what's broken. And so it's way upstream of that. And so it's really like boom when something hits and it's that first like of the cell to say what's going on here. And so this in it, and because it's so upstream, it's very broad, right? This isn't, the fiddlegrass is a great molecule, and it's very specific for dry eye and very specific for these different receptors, and it works really well. Don't get me wrong, but this is just very different in that it's so upstream, it's so broad. It's going to radical aldehyde species are released with infection, with autoimmune inflammation, and without any oxidative stress like injury. So it's just this broad spectrum, and that's why I'm so excited about it, is because there's such opportunity to do different things. It's nice to be specific and focus on a target, but it's also nice to cover your bases. I mean, we all see how much Tobradex is prescribed in optometry, and I think there's a reason for that, right?
Yeah, I think I saw some of this data and it looked like it actually just works really quick too, because that's the other thing. We always want everything to work quickly for our dry eye patients. They're uncomfortable. And I don't know if you can speak on some of the data that was published or some of the studies on RASP inhibitors and how quickly that we might see that work, and also any application in the allergic space as well, and how we can help with allergies with maybe a RASP inhibitor.
Right, 100%. So yeah, they because of that broad spectrum, we're thinking about allergic conjunctivitis too. Has helped with a paper on Reproxalab and allergic conjunctivitis, showing that it was effective. And you're right; it's very like industries listen to the call. We all said like it stinks that our patients have to wait this long for this to kick in, and we've seen that go from 6 months to 3 months to 6 weeks to 1 month. And so we've been moving that forward. So everyone's been trying to answer that call. But if we think about how upstream this is, really, this medication is working at the instant it hits those radical aldehyde species. So I hate to say instantaneous results, but instantaneous biophysical change, which is going to lead to a much, I think what we'll see in the data once it's published is much quicker response.
Yeah. I think there's going to have to be some, education behind RASP inhibitors. This is something before I started learning about this, in working with one of these companies, I was like, I have no idea what a RASP inhibitor is. So I think there's going to need to be some education around that. But I think that's a great way to explain it, is that it's just working so much higher on that inflammatory response cascade, which is great. Another thing in innovation in the dry eye space are these TRP receptors on the cornea. So that's something else I want to talk to you about. I know I feel like been talking about this for a little bit. Just in lectures, I've heard you speak about it. But TRP receptors are another really novel way to target dry eye, our dry eye patients. Can you talk a little bit about those? What TRP receptors are?
I'm just really excited that you pay attention to my lectures like that.
That's because you forced me to do it with you. It's the only reason I know.
Yeah, I put you on stage. That's the only way I can get you to pay attention.
I pay
Stand
attention
next
if
to
I
me.
have to be on stage. That's it.
Yeah. If we can keep your phone from playing AC/DC in the middle of the lecture, but I'll leave that story for another time.
Another time.
So TRP receptors. So we've kind of really, I think NK and Synergimen really kind of opened the door for us to say, holy moly, as we say up here in the Midwest, there's a lot of nerve endings in this cornea, and they're there for a reason. And we've kind of been ignoring that as a therapeutic avenue. And so TRP receptors are these neuroreceptors. And as the cornea has 400 times more receptors than your skin, it seems like an obvious place for using a therapeutic. And so TRP receptors are, especially TRP8. There's actually I think there's 50 or something like this, different TRP receptors, and they all kind of do something different. Some are for detecting hot, and some are for detecting very cold or freezing temperatures like we have up here in Minnesota and Wisconsin. And then some are kind of in between, and the specific one being looked at is TRPM8. TRPM8 is kind of what detects cooling, right? That kind of cooling feeling you feel if something would be described as cool. And so that's what happens when tears evaporate, right? When tears evaporate, evaporation causes a cooling or would that be endothermic reaction? So you feel that, and your nerve endings feel that, and they're like, hey, we're having evaporation here. we all know how important evaporation is in preserving the ocular surface. Say, hey, we're evaporating, it's time to make more tears. And so if we can use that receptor as a way of like turning up the volume, like, hey, your amplifier has been turned down by ocular surface disease to 8, we need to turn it up to 11. We need to turn up the volume. Maybe we can use this TRPM8 as a target for a therapeutic to turn up the volume so you have actually natural tear production as opposed to artificial tear supplementation and things like that.
I think it's gonna be really exciting when I think about some of my patients that love that cooling sensation, right? Like there's that over-the-counter eye drop, Roto, right? And I've always wondered why patients just some just really click onto that, right? Like they like that cooling effect. And so, but of course the ingredient deck in that is not ideal for any ocular surface. So, this isn't Roto, right? But just kind of like thinking of those sensations. And I had no idea that there were so many different corneal receptors until we started deep diving. Like there's one for cinnamon, right? There's one for like different chilies. It's like this whole new world, which is going to be really fascinating.
Super cool that we're understanding it to that level, right? Like people are thinking about this to that level.
So true. I like that you brought up NK. Neurotrophic keratitis has definitely caught a lot of attention in the education world because of, just it's a common dry masquerader, and checking corneal sensitivity is an easy thing that we can do in our offices. There's a new Brill device, right? That aesthesiometer that kind of can check corneal sensitivity. Can you tell us what you know about it? Have you had any experience with it?
Yeah, I got to play with it 2 weekends ago at the Twin Cities Ocular Surface Disease Symposium. So we're got hands-on playtime with this device, and so yeah, they've come out with an aesthesiometer to help like quantify how neurotrophic or actually neuropathic a cornea might be too. So they're taking on both challenges. This device uses air to stimulate mechanical reception on the cornea. So we have to acknowledge like there's different receptors, right? So if you get poked in the eye, that's mechanical. If you get bear spray in your eye, that's chemical. So if you stick an ice cube on your eye, that's thermal, right? So they'd have all these different receptors. This one's using air as a mechanical stimulus to the ocular surface, and it's controlling that air puff. So it's not your NCT, but in the same realm, like it's using air to puff onto the eye and see if the patient can detect it, like we do with the cotton wisp or the Cochet Bonnet. And it's actually pretty cool. It was way less puff than I thought it would be. And it was interesting how you can feel it. I even did it with and without my contact on and different things. So they're trying to scale that. And of course, a patient with neurotrophic keratitis wouldn't be able to feel anything with the highest setting. But then you can quantify it where there might be just a little neurotrophic. And they also had a low setting where if the patient's hypersensitive, right, they shouldn't be able to feel this, and they're like, oh my gosh, that's excruciating. Maybe there's some disconnect, like neuropathic eye pain.
That's interesting. It might be a nice way to like monitor patients as you're improving their level of neurotrophic keratitis if you can use that device to monitor improvement. It's interesting.
Yep, for sure.
I was gonna say, it also makes me think about if we should be screening corneal sensitivity more. Like I'm thinking for patients with diabetes, right? So when they go to their like that's something that's kind of on the forefront. Should we be doing this for every, diabetic patient, right? Or patient with diabetes? So
And there
possibly.
might be some like association, right? Like, hey, this patient's losing nerve function in the cornea. You better be checking their feet more, or they're more higher risk for retinopathy and other issues. So there's probably some associations. That's a great point, Jessilin.
I feel like, if we ended up implementing this for more patients, we would find out that it probably isn't as rare as what we think it is. One thing that I feel like hasn't had a ton of innovation in a space is the punctal plug space. So that's something that I feel like has been kind of the same old, plugs that we have known for decades. But now there is something new. There's something called Lacrophil, which is this canalicular gel. It's not at all a silicone plug. It's not a dissolvable plug. It's something very different. Have you had the chance to use this yet, Jake, in your clinic?
Yeah. Yep. So yeah, it's a hyaluronic acid gel, right? So they've kind of like thickened up this hyaluronic acid. And if you just think about it, right, you're putting a gel into the puncta, and putting it there and just leaving it there. And so, of course, it's going to block aqueous, or tear film, I guess, from getting down the pipe. And so, really simple thought process here, but it's not hard. It doesn't have a cap. It's going to go away eventually. So, kind of taking that punctal plug experience, which I think we've all had, and trying to evolve that. That's awesome. So yeah, it's just a syringe, very simple to do, just like you do with irrigation, but you're putting something down there that you want to stay put for a while. About 6 months it should last.
Any contraindications or things to be careful or cautious of?
I mean, I think you have to be conscious of how much you're putting down there. I don't think you want this coming out the patient's nose. Um, So we're just trying to fill a very small area. This is a very small volume. Um, but other than that, like our plugs, we're going to be backing up the system. So any contraindication for punctal plugs would be a contraindication for this. The nice thing is, it's a gel. So I think if you really wanted to irrigate it out of there, you could irrigate it out of there much easier than you could a plug. You could get out of there if something were to arise, but very, natural type material that would be safe.
Yeah, I think that's kind of nice. It doesn't involve any sizing like we, have to consider when we're doing plugs now. I was wondering about, this gel, if I just want to plug the lower and I want to not plug the upper, I was wondering how that might work with the gel, like how is there a way? I mean, have you found that if you're plugging the
Yeah,
lower, you're accidentally plugging the upper also?
right. I think if we're kind of learning, experimenting with that, but I think if you can control like pressure, so if you can, press on the upper part, press on the upper lid and the upper part of the lacrimal system, and prevent the gel from going that direction while you're inserting it. But a lot of it probably has to do with like a feel, right? Like I'm going to put this much in and that's enough. So it's probably a little bit of feel and a little bit of prevention by using digital obstruction of the rest of the system.
I like it. Exciting things. Is there anything in particular coming down the pipeline that you're just really stoked about that maybe we haven't like hit on?
Yeah, I think like I said, I'm really excited about. I think there's another generation of biomolecules that are coming too that we can't speak to and don't really know much about, because these things take so long. But I'm excited about stealing rheumatology. Instead of having these infusions for these patients that do all these things, if we could harness that power and put it into a therapeutic just directly onto the ocular surface, I think that's huge. I'm excited about. I'm just excited in general. Let's just be honest. Um, I'm excited about this. There's a anti-cherolytic drop that's coming or that's being evaluated more like towards Australia, I think is where they're doing the research, Australian company, but it might be the a chemical way of removing obstruction within the meibomian glands. So like mask and probing in a drop. So that's kind of exciting. What about you guys? You guys know more, just as much as me. Like, don't sell yourself short. What have you like heard that's like a interesting story or a compelling story?
Honestly, I'm really excited about these trip receptors. I think this is like a really unique way to target dry eye, and it is it's like it's something very new, I think, to the profession, along with the RASP inhibitor. Although I feel like we've been hearing about the RASP inhibitor for a little bit, the trip receptor seems more new, and I think having these new novel targets is really important to try to improve outcomes for all the things that we do have. We certainly still have patients that don't improve the way we want them to. So having some new innovative ideas are always great.
I agree. I think the two ones we discussed are really helpful. I'm also excited about the Demodex pipeline, right? Demodex has really had a big year this past year, and we're seeing how prevalent it is. And our current, with XDMV linear being on the market, it works great. But just sometimes when you have more players, that improves access to care. And sometimes when we prescribe things, that managed care aspect can sometimes be a little bit limiting. So lots of exciting things there. I just like having the idea of more tools in the toolbox to just be able to help more patients, which is really great. So Well, Jake, this wouldn't be an episode of To the Point if we didn't at least kind of see what your life lens is, throw down some other wisdom
All right.
outside the dry eye space. What would be your life lens?
Yeah, something that makes my life easier. I think first I think about like my phone and like my calendar, right? Like my wife is a big paper calendar person, and like I realize when I'm starting to talk about this stuff, like especially at meetings, like I live by my calendar. Like it tells me where to go. It tells me, and recently some of my partners like don't send Zoom links. Like they were gonna do a virtual meeting, but they don't send a Zoom link. They're just like, oh, just call me and we'll hook it. I'm like, I don't have a button to click, like a Zoom link to click in my calendar. Like I'm lost without that, right? Like you're like, what do I do? And it's gotten so smooth and easy with those links. I think that's huge.
Yeah, if
Um,
there's not a Google Calendar invite, like forget it. It's gotta be sent.
Gotta be there. I love a good paper planner and a paper calendar, but it just does not work for me anymore. But I used to be very into that. I love that your wife does that.
she's great at it, and
I bet. All right, Jake, thank you so much for taking time out of your evening to talk with us about dry eye innovations. It's always so nice to talk to you and hear your opinion on these products. So thanks again for being
it's
here.
my pleasure and honor. I love what you guys are doing, and keep up the good work. It's always fun.